Good evening, and welcome to the inaugural Interventional Pulmonology Update Series. This is the first time we are doing this in this format, and so far everything has gone as well as we could have planned for. It's always been one of our dreams to have an interventional pulmonology community, and we do have one in Perth, and there are communities in other parts of Australia as well. One of the reasons why we thought having something like this would be a great idea is to bring all the communities together. The idea is that we could run a series through the year where the event can be held in different parts of the country with a face-to-face event in each city which hosts it. But at the same time, it can also be streamed across to anyone who is part of the TSNZ. And the response to this event has been very overwhelming. We have had about 60 plus registrations for the dinner here tonight, but also have had more than 100 registrations for the webinar that is being streamed across. I was told that more than 50 people have registered or have actually logged in just as I started. So that's great. So thank you all for coming for this meeting. And we thought we would have the first talk or the first symposium on lung volume reduction for severe emphysema. And I knew it was a topic that is of great interest to a lot of us, but I just didn't realize it was of great interest to so many of us. There's so many people here who I didn't actually realize were interested in this, and the same across the country. So it's great, and we have great speakers, although one of my speakers hasn't turned up yet, but hopefully, I'm sure he will turn up too. I'd like to start by acknowledging the Whadjuk Noongar people as the traditional owners of the land on which we meet today, and pay respects to the elders past and present. The Whadjuk Noongar remain the spiritual and cultural custodians of their land and continue to practice their value, languages, beliefs, and knowledge. I'll start with a couple of housekeeping points. Bathrooms are on the right, the exit is on the left, and the bar is also on the right. Please switch off your phones or at least silence them. I'd also like to acknowledge the support of Pulmonx, who have sponsored this event for us. And as I said, we got great speakers. Phan Nguyen, who most of us here know, he is the head of department at the Royal Adelaide Hospital, probably has one of the most experience in lung volume reduction, bronchoscopic lung volume reduction in our country. He has kindly agreed to give the first talk. I know I pushed you, Phan, quite a bit. I got him here for a course, and then I just asked him more and more things to do, and he's always said yes. So that's great, thank you. And the same applies to Alvin as well. Alvin is the professor of respiratory medicine and interventional pulmonology at Macquarie Hospital. And again, Alvin has come down for the course, but has kindly agreed to give the talk, and it's fantastic to have two of the most experienced people in bronchoscopic lung volume reduction in here. And of course, there is our surgeon, Pragnesh Joshi, who's just finishing his last case. He's arrived? Oh, there he is. Oh, perfect timing. Surgeons are very good at timing their arrival. So thank you, Pragnesh. I can relax now. So Pragnesh is our thoracic surgeon at Charles Gardner. I love working with him. He's fantastic. And he's going to give us, I'll talk about what the titles are in my next talk. But so we got people across the spectrum, physicians and surgeons. And if Alvin and Phan wants to have a debate with Pragnesh, I'll leave you to fight it out with each other. But Pragnesh is a nice guy. All right, so the program for tonight is Phan is going to start off with assessment and techniques for endobronchial lung volume reduction and severe COPD with complete fissures. And then Alvin is going to talk about the same techniques, but in those who have incomplete fissures. So that, I think, covers the spectrum of patients with emphysema who would be eligible or suitable for bronchoscopic lung volume reduction. And Pragnesh is going to talk about lung volume reduction surgery, when not, whom, and how. On this point, I would like to invite Fan to come and give his talk on assessment and techniques for endobronchial lung volume reduction in severe COPD with complete fissures. To those who are online, welcome. It'll be great. It's a bit hard to have a two-way interaction because I think that will make things a bit messy. But if you have any questions, please type in the chat function for Zoom, and we'll try to address those or get those questions asked from our presenters. Fine.
Thank you, Rajesh, for inviting all of us to present tonight. You've done an incredible job getting this together, but not just this, but the CTEC course, which we've just all completed today. So when Rajesh asked me about this, I didn't realise it was going to turn into a formal dinner and an online symposium. But always very happy to say yes to my friend who's kindly invited me to speak tonight. So my topic is really to cover lung volume reduction in patients who have fissures which are intact. And in Australia, the main technique that we have for that is endobronchial valves, if you're talking about bronchoscopic techniques, but obviously you can consider other techniques as well, and I'll touch on those, but I'll let Alvin and our surgical teams talk about what they can offer as well. So in terms of disclosures, these are my disclosures which could potentially relate to this talk today. So in terms of techniques for intact fissures, valves probably have the greatest body of evidence, and we'll talk about the impact of collateral ventilation in terms of patient selection and workup. So we have the Zephyr and the IBV valves in that group. For a shortish period of time, we also had bronchoscopic thermal vapor ablation. In terms of the centres around Australia who offered this, most of us tended to look at a reversible treatment first and then consider vapor after, but that's unfortunately just lost its TGA approval not too long ago. Alvin will touch upon possible future directions there. There have been coils, but I think in Australia, less than a handful of patients have been treated with coils. And of course, you can definitely also consider lung volume reduction surgery as a treatment for patients with intact fissures. So I just highlight this article which Alvin's group published not too long ago. I think for us it's been quite a few years. For me, it's been about 7 years getting things up and running in Adelaide. But I think even prior to that, Alvin and I were running very small courses looking at this as we established this as an accepted treatment for COPD in Australia. So Rajesh asked me this morning to present at the CTEC course on this, and the structure was really quite nice to think about why you would do this, how, when and when not. So I'll just put forward a few slides about this to begin. Why? Our COPD patients have quality of life issues just as much as our non-small cell lung cancer patients. They have symptoms. There's quite a big impact of hyperinflation on not just mortality but also quality of life. It affects their shortness of breath, their exercise tolerance, and can certainly affect their BMI and muscle strength. So in terms of the GOLD report, endobronchial valves for patients with intact fissures have been part of the standard of care probably since about the 2020 GOLD guidelines, with level evidence A. Coils and vapor ablation are in the B category, and you can see at the top there, lung volume reduction surgery certainly is evidence A, and there was a recent trial comparing the two which showed favourable outcomes for both groups. The other Y is the survival benefit. There is a survival signal for patients who are eligible for lung volume reduction techniques. You could, of course, dive into the selection criteria. It may be that those patients who were eligible may potentially be slightly fitter, but certainly there is a survival signal there. I won't cover every single trial, but this has been the history of valves through the years. I'll probably talk about the VENT trial, mainly to talk about the impact of collateral ventilation and how that affects our choice of patients. The NET trial was obviously the landmark surgical trial, which first showed the benefits of volume reduction surgery. So the lesson from the VENT study, both the US and the European studies, this is sort of what I say to my patients. Look, the initial trials showed a very mild benefit in terms of both quality of life scores, FEV1s, and volume reduction. And it wasn't until they looked at the data afterwards that patients had to have the whole lobe treated. You had to stop all the airflow to that lobe, and you also had to look at the fissures. So if the fissures communicated with each other, it sort of didn't matter what you did with the valves. Air would leak in from the back or from the ipsilateral lobes. So those were the two key things. Once you looked at that subgroup analysis, there was a definite treatment signal there. So essentially, many of us, both here and online, know that collateral ventilation is airflow between lobes. So it's through channels that bypass the normal airways. So only lobes that have little to no collateral ventilation should be treated with valves, whether there's EFA valves or IBV valves. In our group, we have a radiologist who looks at the fissures for us and gives us an expert view, but certainly you can get software such as Vida, Thorona, which is the StratX rebrand, Philips or Siemens, to look at the fissures. So this is a fissure report that you might get from a program which analyses it objectively. This is a Thorona report or a StratX report. And it's just showing you how complete the fissures are. Generally, when you get above that 95% mark, you're pretty confident that the fissures between the lobes are going to be intact. Just a view of the fissures. Usually the left one is the easiest one to look at. Often on the right, you might get a bit of a deficiency immediately, and that's a little bit harder to detect. The second test that we often do to look for collateral ventilation is to do a Chartis assessment. That's a proprietary device. So the system, I'll just let the video run as I explain this, but the system has a balloon catheter which at the end of it has a device which measures both pressure and flow. So the orange line here is your flow line. So it's measuring the flow, and the blue is your pressure. Now, you can occlude either the target lobe or the ipsilateral non-target lobe. Once the flow drops off and the pressure rises, then that means there's no collateral ventilation between the two lobes. That way you can be more confident that if you do block the airflow to your target lobe, that no air will leak in through the ipsilateral lobe. So this is what we call, I guess, a textbook CV positive reading. You can just see throughout the assessment there's just no change in flow. It's unlikely to respond. In this patient, you can see the flow drop off and the pressure rise, and that patient is likely to respond. So these are some of the studies showing the various benefits. They've got various follow-up periods, between 6 and 12 months. Lung function FEV1 goes up by about 15 to 20%, 6-minute walk distance anywhere up to 50 to 75 metres, and the quality of life scores generally are all significant. These are the more specific CV negative trials. Because the US VENT study didn't determine initially the need for both CV negative as well as low bar occlusion, the Americans were behind the rest of the world in terms of starting bronchoscopic lung volume reduction. So they had to repeat some of these studies with this in mind. And hence that's why you've had these Liberate and Transform and Impact studies come out to satisfy the American side of approvals. So the Stelvio was one of the first landmark RCTs published in the NEJM, which used Chartis to determine no collateral ventilation. You can see the parameters there. If you look at the overall response rate, about 75 to 80% of people were classified as responders based on the MCID criteria. So the Liberate was the US study to help determine the eligibility of valves in the US. And again, they showed significant improvement in FEV1 and 6-minute walk tests. And the other two final studies to finalise the literature group were the Impact and the Transform studies, which again showed improvements in FEV1 and 6-minute walk distances. So that's an overview of, I guess, both collateral ventilation and the impact of collateral ventilation and the evidence behind endobronchial valves for lung volume reduction. This is generally our patient workup. Surprising, we still sometimes get patients who are sent to us who are smoking. I think if they're an exacerbator, and we know with COPD patients, if they're exacerbated, they tend to do a bit more poorly. Exacerbators tend to also potentially be exacerbators with valves. So that's just something to keep in mind. That's a little bit of a signal that we're seeing in our patient cohort. I think if they have a lot of mucus and bacterial colonisation, you'd think twice a little bit about doing this type of procedure. You want to make sure they've done rehab and that there's no other significant comorbidities. If I'm the person assessing the referral for the first time, it's really nice to have all the lung function done, the 6-minute walk tests, and potentially a blood gas. The quantitative CT, that's often something we do later if needed. And we also do a ventilation perfusion scan, which I'll touch on briefly in terms of our assessment of which lobe to choose. The QCT, even if you, I guess, have done a CT prior, as long as they're thin cuts, most of the software can work out which lobe has disease, which lobe doesn't, and we can normally go from there. These are our general inclusion and exclusion criteria. The age is not a hard cutoff because you often see very good 80-something-year-old people. In our early days, we even had residual volumes as low as 150, but we feel 175, 200 is probably a better number to look at, especially if they've got homogeneous disease. And then I describe these people as like Goldilocks patients. You don't want them to be too good, and then you don't want them to be so bad that they might not survive the anaesthetic. So these are our general exclusion criteria. The 6-minute walk distance, it's roughly 140, 150. That's what we use as a cutoff. Some centres may even go down to as low as 100, so we can always ask Alvin his thoughts on that. But these are our general exclusion criteria. So as part of the assessment, the QCT basically just uses a Hounsfield unit density measurement to say what's emphysema and what's not, and it's generally a pretty hard cutoff. Minus 950, I think, correlates better pathologically in post-mortem studies, but certainly some studies have also used minus 910. So just think of it as a software calculation. This is emphysema, this bit's not, and then it gives you a percentage of how much emphysema is in each lobe. And those are the cutoffs for what's called heterogeneous and homogeneous disease. So this is a report that you might get back with an objective analysis of the emphysema disease. So here, the first line is your fissures, and these are the two different densities that you see. I think probably the 950 is a better marker, because otherwise if you look at 910, then essentially that whole right upper lobe is wiped out essentially. But here it's saying it's 66 compared to 25, so you say this person is heterogeneous on both sides. 53 left upper lobe, 31 left lower lobe. And that's, I guess, a nice colour picture of it in action. The patients like to see the colours more, I think. So I'll just quickly talk about the two different valves. So this is the Zephyr device. So this segment here is your landing zone, and that's where generally the shoulders of the valves finish proximally. These are your sizing wings. You want the larger wings to touch the segment that you're treating and the smaller wings to not touch. So the line there, in the newer devices, they're the same colour as the valve, but that tells you where the valve is going to sit in relation to the airway. So the blue valve is your small one, and then the green is the large, and they both have different lengths, so that you can potentially put in a shorter valve if the place that you want to put the segment in is quite short. Otherwise, if it's sticking too far out from the segment, there's a risk the patient will cough the valve out. So we do this fan and deploy technique. So we generally aim for the carina, and we partially fan out the valve, push it onto the carina, and then complete the deployment. So it's all done down a working channel of a bronchoscope. So that was a blue one, a small one going in. This is from Dirk Jan and Karen's talk, their paper in chest, showing a larger valve, the green one, being partially deployed first, pushed onto the carina, and then fully deployed. So the umbrella valve, or the IBV valve, has sizes from 5 through to 9 millimetres in diameter. The volume reduction escapes around the umbrella, and any mucus escapes around the umbrella. So it goes from 5 to 9, and it shows you the length or the landing zone that you need to place that valve. So the landing zone is potentially just a little bit longer, so you need to consider that. With the IBV valves, you do need to calibrate the sizing balloon prior. So they have a calibration disc, a little calibration balloon, which you pop into the various size discs, and then you write the volume in the glass syringe on the graph to your right here. And then once you go into size the airway, you look where the volume is on your syringe, and then it tells you, which size valve you should load up. So complications, everyone wants to hear about complications. The one that stresses us out the most is pneumothorax. Generally speaking, most of them occur in that first 4 days. We keep our patients for about 3 days before we send them home. And the theory is that you're tearing the ipsilateral non-treated lobe because the volume in the treated lobe is reducing too quickly. Pneumonia, COPD exacerbations, and about 5% or less of people can potentially cough up the valve if it's not sealed well enough. So that's the general literature in terms of the complication rate. Jerry Kreina's group looked at the pneumothorax occurrence and just demonstrated that the vast majority happen in that first 3 to 4 days. So our advice would be always to keep the patient for around about that 3-day mark. There's a nice algorithm in respiration that tells you sort of what to do if there's pneumothorax. If it's small enough, you could potentially wait, but almost all the time I think they need chest drains. if the air leak has persisted, at 5 to 7 days, then you remove one valve. And I always say to people, remove the one valve that's easiest to take out, because then that's the easiest one to put back in. If the pneumothorax has persisted after that, then you would then look at removing all valves, and then after that you'd have to call your friendly surgeon to lend your hand. We've had to call our surgeon once in our 60 patients, but the others have generally fixed themselves with drains or valve removal. That's the algorithm. I've heard stories of people being told when they're on call after someone's done a valve, this is the algorithm, can you follow it? I think this slide can be a bit difficult, but I think the other slide is probably where you want to be. So I might show the second set of CTs actually, because they scroll a bit better. But this is sort of a case example of a coronal reconstruct of our patient before treatment. You can see quite flat diaphragms. This is your lower lobe here. And we had to, you could just quickly catch the valves there. We had to do a redo on that one because we weren't getting lobar collapse. And as you can see now, the diaphragm is higher. You can't see that fissure anymore because as we come through, that lobe has now collapsed. So we've managed to volume reduce that left lower lobe. I'll just touch quickly on the CELEB trial, an RCT comparing both surgery and bronchoscopic lung volume reduction. Both groups did well. One, it demonstrated that valves could work, but two, it demonstrated that patients selected well for surgery could also do quite well. So just to finish, I thought we'd just describe our experience in Adelaide. So we're two centres, Royal Adelaide and Queen Elizabeth. Commenced February 2015. We've got a MDT team of a radiologist, a very enthusiastic nuclear med physician, thoracic surgeon, thoracic physicians. We had to go through a new procedures committee through the Central Adelaide Local Health Network. We had proctoring with international experts, discussion with national experts, our friends in the room. I had to say hello to Farzad online, otherwise he'll get very upset. My friend in Brisbane, Farzad, other experts in Victoria, and I've had many conversations with Rajesh and Martin when he was back in WA. We had these small training courses, Alvin, I still remember those. And then we've got a committee in South Australia called the SA Policy Advisory Committee on Technology. They could potentially stop you if they notice you're gone crazy, done too many valves, killed too many patients. So I had to present our data, both at 18 months and 5 years, and now it's quite well accepted in our state as a treatment modality. It's actually published online, I realised last night when I Googled it. I always like to embarrass Sarah in the back. This is Sarah just there. That's me, as you can see, because I'm the shortest person. And you've got DJ and Karen. There's Hubertus, ahead of unit, Paul Reynolds there. This was obviously pre-COVID, no one's wearing masks. And some of you might know Justin. Does he, he was my reg at the time. He was doing consultancy by that period before he came back to Perth. Love Justin, so he threw his face in the side there to photobomb it. We do a VQ lobar quantification. So the traditional way that VQ is done is planar. It gives you a zone, upper, mid and lower. This is something that we've collaborated with the Macquarie Group. They've been very interested in this as well. Alvin and I have spent hours trying to work out the maths and why does the nuclear med physician divide this by that to give a certain percentage. It works. He's published a technique in a separate nuclear med physician journal. We find this quite useful in homogeneous disease because you sort of want to work out what's the sickest lobe next to the healthiest lobe, because you want to treat the sickest lobe next to the healthiest lobe, not a sick lobe next to a sick lobe. And that's really helped us quite a lot in our homogeneous patients. He's extended this to sort of pre-surgical assessment, in addition to the stair test as well as the bike test, and our surgeons are finding this quite useful as well. And we're in the process of trying to prove that in a clinical trial. These are some of the results from Vanessa's paper, which I just showed before. So when we had to go back and look at our cohort, this is our sort of 6-year experience. And I thank Michael Brown, our fellow, for putting this data together. And he's always emailing me saying, can you please check the paper so we can actually submit it? And so I'm the rate limiting step. So I apologise for that. But about 75 to 80% of our patients get target lobe volume reduction. And by that we mean a volume reduction in the target lobe of either 350 or an overall RV of 430. We get about 50% total lobar collapse. Perhaps Alvin can comment on his experience. But you do notice a bit of a drop-off in the RV as time goes by, and sometimes I think the remaining lobes get greedy. It's very hard to predict who that happens to, but generally speaking, the quality of life scores are persistent for at least 6 months. So I wanted to embarrass Andrew, one of my colleagues. That's him on our social network in Adelaide, talking about his trial. He wants to look at the cardiac effects of lung volume reduction procedures. And Alvin, I think we've been talking about this since Canberra. So it's just been a bit slow with COVID recruitment, but I reckon we're about halfway there. These are our complication rates, which are generally in line with international standards. Strangely, we've had 2 patients subsequently develop collateral ventilation down the line. I don't understand the mechanism behind that, but that has happened in 2 of our patients. So just to finish, in summary, interventional procedures for COPD, valves generally have the strongest data, especially where collateral ventilation is absent. There are alternatives, and I look forward to hearing what Alvin has to say. But I think having correct patient selection and MDT and dedicated centres are quite important. I'd just like to really thank our nursing staff. They are an amazing bunch. They know what I want before I know what I need. So, it's a really great team to work with, and I really am appreciative of all the efforts that they put in. My colleagues who do many of the procedures with us, Michael, who's prepared a lot of this data, Guy is a very enthusiastic nuclear med physician. He's unbelievably enthusiastic about this, and our anaesthetic and CTSU staff, so we'd just like to thank all of them.
Thanks, Van. That's a lovely talk. Very nice overview of lung volume reduction. I thought I might get Alvin to do his talk, and then we can take questions, because I think it'll be good. The questions will be relevant to both of your talks. So, Alvin, please give your talk on lung volume reduction in patients who don't have collateral ventilation. Actually, do have collateral ventilation.
Thanks, Rajesh, and it's a privilege to come to Western Australia. I've been here many times, but never for a respiratory reason. So it's great to be invited over here, Rajesh, and it's good to be talking to both you here and also online. I'll just start off with my disclosures, and my current disclosures relevant to this talk. But I'll start off with this slide, which you've already seen from Fan. And the reason I think that's quite significant is that endoscopic lung volume reduction has been something that most of us have been thinking about, those of us in the game at that stage, from about early 2000s. There was a paper published in Chest, small series in 2005, and at the ERS in Stockholm in 2007, there was a very heated plenary session whereby there was a lot of debate as to whether or not this was an appropriate technology. The Chest papers showed a significant improvement in FEV1, but it was only about 30 mils. Significant improvement in SGRQ, but it was about 5 or 6 points. So the question was, these are clinically significant, so these are statistically significant, but are they clinically relevant? And there was a lot of heated debate over that, and what we learned over the subsequent years was that it's all about patient selection, and it's about looking for the right signals. And collateral ventilation is a very important signal. And if you look at the VENT study, which was published in New England Journal, I think it was 2008, 2009, if you had collateral ventilation, there was really no significant improvement. But if you didn't have collateral ventilation, that's when the benefits occurred. So, having said that, Phan's already touched upon the importance of a multidisciplinary approach. And we involve our radiologists, a specific pulmonary radiologists, as well as cardiothoracic surgeons. And I think it's really important to have that diverse sort of approach, given that there are many potential options, particularly in those patients who have incomplete fissures. So, like Phan, we run a IPMDT every couple of weeks. This is the ELVR expert panel recommendations published in Respiration quite a number of years ago. It hasn't changed. And you can see the recommendations are divided between, if I can get those that have complete fissures, or FI, complete fissures, and those that have incomplete fissures. And the recommendations look pretty similar, if you ask me. But the bottom line is that if you've got complete fissures, then the evidence with all the RCTs that Phan's presented is that of endobronchial valves. The important thing, I think, with any technique, whether it be with valves or any other techniques that I describe, is that you want to achieve volume loss. And volume loss predicts improved symptoms, improved quality of life, as well as improved survival. And there's quite a few papers looking at it. There's just 3 papers looking at improvement in survival if you achieve volume loss in those that have had ELVR. If you don't achieve volume loss, then the mortality, the symptoms, the lung function is significantly worse. So the aim is to achieve volume loss, and even partial volume loss is associated with improved prognosis. So this is the actual algorithm I use, as opposed to the algorithm I showed you from the expert panels. And basically, we're looking at fissure integrity. So if your fissure integrity is greater than 95%, then I think valves are where the evidence is. If your fissure integrity is between 80 to 95%, then we should do the Chartis assessment, which Phan has already described. If Chartis assessment suggests that you've got no collateral ventilation, you may consider valves. If Chartis assessment suggests you've got collateral ventilation, then I'll talk about some of the options. And if your fissure is less than 80%, then there's quite a lot of investigational sort of therapies, and I'll talk about some of them that we're involved in Australia. The evidence of those is quite early at this stage, but I'll just give you a taste of what some of us are doing in this space here. So we've been doing valves, I think, since 2008, 2009, and we've refined our selection criteria over that time. But the thing that concerned us or upset us a bit was that patients were referred around Australia for us for endobronchial valves, and we couldn't do it in more than half for various reasons. Some of those include that they're still smoking, but a lot of the time was because they had incomplete fissures, so we didn't have a therapeutic option. So we looked at the potential of using a product called Aeroseal, which is polymer foam sealant, with the idea of trying to seal the fissures and then put valves in. And Aeroseal is not a new product. It has been used in the past to treat whole lobes, but the volume that was used in the past was 80 to 120 mils. That caused significant inflammation and also resulted in significant side effects. And it was probably discontinued from about 2014, 2015 because of those side effects. So this is the type of patient that we would look at. So this is our first case that we did, a proof of concept. And this is a patient who had 83% complete fissures on the left, 56% destruction scores at minus 910, 37% at minus 950. So you're going to say, well, why didn't we target, we targeted left upper lobe. You're going to ask, why didn't we target right upper lobe? And if you look at CT SPECT, lobar ventilation perfusion, and the lower it is, the worse it is. This is when I got to talking to Fan, and also Guy, who's Fan's quite correct, is really passionate, overly passionate. You can see that the lowest VQDI, so the lobe with the lowest ventilation perfusion index per unit volume, was the left upper lobe, much more so than the right upper lobe, and that's why we targeted the left upper lobe. And you can see the fissure defect is in red, so you can see quite a large medial fissural defect, which accounted for 17% of the fissure on the actual Thorona assessment. And you can actually see the fissural defect on the sagittal CTs. And what Thorona did for us and what Pulmonx arranged for us was to look at how could we get polymer sealant into the area of the fissure, and could we seal it? And we were able to map it to LB4 and LB5 segments. So this shows that 49% of the fissural defect could be mapped to LB4, and 50% of that fissural defect could be mapped to LB5. This was the patient's charters of the left upper lobe before we did anything. And it's a little bit up and down, but essentially there was persistent flow despite occlusion of the balloon in the left upper lobe, indicating that there was collateral ventilation. So Aeroseal is a foam polymer. It's basically like a fancy aerolite, to be honest. It consists of polyvinyl alcohol and glutaraldehyde. It's a substance that's been used in the past, but we've repurposed it for, rather than causing lung volume reduction, we repurpose it to try to seal fissures so you can prevent collateral ventilation. You basically instill it endoscopically under direct vision with the balloon. The balloon prevents reflux and backflow of the polymer sealant, but once you let the balloon down, a little of that sealant does come up and you can see it. And I did not rip this off a Pulmonx website. It's a true indication of the first patient that we did. That was CV negative with reduction in flow after 2 minutes. So this was proof of concept that instilling polymer foam sealant into a segment that subtended the fissure could prevent collateral ventilation. And so we proceeded to perform endobronchial valves into the left upper lobe. That's LB1, LB12, LB3 and LB45 that you can see there. And this is what happened to his X-ray. You can see that this was after polymer sealant, and this was after endobronchial valves to significant volume loss. And if you look at his lung function prior to his, this is 2018, so 2019, so prior to his endobronchial sealant and valves, he was 0.83 pre and 0.98 post. And afterwards, there's a little bit of reversibility, but significant improvement in FEV1 and significant reduction in RV. So that led us to, that was a proof of concept, and that led us to doing a randomised controlled trial. It's not truly randomised because it's fissure or no fissure, but we matched the two groups. Those that had collateral ventilation into one group, and those that didn't have collateral ventilation in another group, and we wanted to see whether or not instilling Aeroseal sealant to reverse collateral ventilation did they have a better or worse outcome than those that didn't have collateral ventilation. And we published this in Respirology last year. So we had patients in each arm, and we matched them for everything except for left upper lobe volume. So left upper lobe volume was slightly larger in those that had incomplete fissures or collateral ventilation positive. And we found a couple of patterns of incomplete fissures. We found some patients who had a medial defect there, who had the entire fissural defect subtended by one segment. This is LB5. These did better actually than those that had multiple fissural defects that had multiple segments that were subtended by the fissure. So this is a patient that had a fissural defect up there and a fissural defect up there, and rather than being subtended by one or two segments, it was subtended by three segments. LB12 accounted for 24% of the fissural defect, LB4 18%, and LB5 57%. So there was a couple of patterns that we saw. So in the group that had incomplete fissures, we looked at their lung function, their quality of life, their left upper lobe volume at 6 months. And there was significant improvement and clinical significant results across most lung function parameters, especially with residual volume, which dropped by probably about 800 mils. The only thing that didn't change was DLCO. And importantly, left upper lobe volume fell by fell by 900 mils, which is obviously quite significant. And volume loss is what we're trying to achieve. When you compare the two groups, the groups that were CV positive and the group that was CV negative, the groups that had positive collateral ventilation, that had aerosil instilled and then valves, had similar improvements in most parameters of those that were collateral ventilation to start with and had valves without the need for sealant, apart from FEV1. So the FEV1 improvement was slightly less and statistically significantly less than those that were collateral ventilation negative from the first place, but they had similar improvements across residual volume and, most importantly, significant improvements in left upper lobe volume, which were no different from each group. And what I said before, those that had a single defect or a linear defect get better than those that had multiple defects. So we concluded from this that there was a potential for a therapy for patients that had collateral ventilation with fissural defects that were between 80 to 95%. And so this is just to show the chest X-ray. This is the baseline chest X-ray. This is the X-ray after we instilled aerosil into the lingula. You can see there's a lot of significant changes in the lingula, consistent with airways inflammation. By about a month, a lot of that inflammation resolved, and then when we put in valves, there's additional volume loss that you can see. So aerosil after a couple of days, aerosil after a month, and this is after valves. So we conclude from that there was a viable therapy for patients that had collateral ventilation positive lobes. And on the back of this, Pulmonx established a multi-centre worldwide trial called CONVERT, and we just targeted left upper lobe. This targets any lobe. Recruitment for this is just finished. 100 patients have been recruited across Europe, South America, Australia, US, and we don't have the results of that yet. The data's still being analysed. In fact, we still have a few patients. We've recruited 16 patients, and we've still got a few more patients that we've got to put valves in after putting the aerosil in. But one interesting thing that we've seen, and it's also been replicated in other sites in Australia that were involved in this trial, including in Royal Brisbane, with Farzad, if you're online, I'm quoting you now. After you put in aerosil, even before you put in valves, there is significant volume loss. Chest X-ray, after 10 mils of aerosil into RB6 and 10 mils into RB8. So we're treating right lower lobe with incomplete fissures, and you can see the significant volume loss even before we put valves in. This is a chest X-ray of patients that we put 10 mils of aerosil into LB7, LB9, and an accessory left lower lobe bronchus. And again, you can see significant volume loss. And the impressive thing is that both lung function and symptoms improve significantly to the fact that patients will ask us, do I really need valves? Obviously, this is very anecdotal, and we don't know how long this lasts for and what the duration of this effect is, but it was an interesting observation. And if you do CTs of them, you do see volume loss as well as inflammation. And the whole point of using this polymer foam sealant is to create inflammation to cause segmental volume loss. So as a group at Macquarie, we've talked about doing segmental treatment with aerosil without valves. And I think in the future, it makes sense to treat the most affected segments rather than the most affected lobes if there are good segments in the lobes that you're targeting, because lobes are not homogeneous. There's heterogeneity within the lobes, but this is just a thought bubble, and we'll see what the evidence shows in the future. So I've talked about 80 to 95%, so let's talk about less than 80%. What's the evidence there? Well, there is some evidence for coils, and there was evidence B, as Fan showed you. Coils in Australia are about $50,000 a patient. It's really quite restrictive, and it really hasn't taken off. I think a few have been done in Brisbane, but I'm not aware of anything being done in the last 5 years. Thermal vapour ablation, which Fan mentioned, was an alternative. There was reasonably good evidence, although in only small RCTs. And the concept of this is treating the most affected segments in one particular lobe. And there was an upper lobe study that was done initially. And it's a step-up program. In other words, you treat the two or three most affected segments on one lung, and then after a 3-month sort of recovery period, you treat the most affected segments in the upper lobes of the next lung. And I think Martin was involved in one of the pivotal studies. This was published in 2016, and it's a controlled trial. And what you can see is that at 12 months, there is significant improvement in both lung function as well as SGRQ when compared to the control group. Small study only, unfortunately, as Fan mentioned, thermal vapour ablation has lost TGA approval for a number of reasons which I won't go into, and is no longer available in Australia. But this is the type of patient that you would do. Patients that had fissures, which were less than 80%, a bit of heterogeneity, and predominantly upper lobe disease, and that's the patients that we recruited. This is the analysis that you get. So instead of getting lobar assessment, you get segmental assessments. So minus 950, you said RB1 is 57% destroyed, RB3 is 49% destroyed, RB2 is 25% destroyed. So you would not treat RB2, you would target RB1 and RB3. And if you look at RB4, RB5 and lower lobes, if you look at the destruction scores and you look at the heterogeneity index, you're really going to treat in this patient RB1 and RB3, maybe at one procedure, and you might treat LB3 at a second procedure. So rather than treating lobes, so if you treat a right upper lobe, you'd also treat RB2 if you put valves in. So, you know, it makes physiological sense that you would target the most diseased segments rather than the most diseased lobes. This is the mapping that you get, how much steam you put in what airway. It's based on the amount of lung mass in that airway, so you're doing energy or calories per gram of lung, there's a way of calculating that. So we actually did 13 patients after screening 23. We presented that data at a symposium in June last year, and the changes were significant. So FEV1 improved from baseline of 27% to 32%. FSC did not improve. RV fell from 257% to 195%. And there was also improvement in 6-minute walk test and SGRQ, but not in DLCO. So it's a very small cohort, but that's the evidence that we have in Australia. These are the changes that you see after the treatment. So this is pre-treatment CT scan. This is after treatment of the right upper lobe, posterior segment. You can see that there is significant inflammation, contracture, and volume loss. And this is after treating the left upper lobe anterior segment. You can also see significant contracture and volume loss. So it's segmental volume loss that you're after. There are side effects. The major side effect is chest pain and hemoptysis. Chest pain because you get inflammation that can reach the pleural surface, and hemoptysis because the inflammation can obviously affect bronchial vessels, and that's something that we're wary of. And in fact, there was actually one death in Europe from hemoptysis after thermal vapour ablation, which actually put a damper on things, obviously, and led to recommendations that any time you're thinking of doing this procedure, you would not use, they should be off anticoagulants, they should be off antiplatelet agents. So there's no longer, bronchoscopic thermal vapour ablation is no longer in Australia, but a number of centres in Australia, including ourselves and also Royal Brisbane, are now looking at endobronchial thermal liquid ablation. What's the difference? Steam is obviously greater than 100 degrees Celsius. This is 95 degrees Celsius with liquid, probably done to get around intellectual property of BTVA. But it's a similar theory using heat delivered to the segmental airways to cause volume loss. and it's a similar principle. And this is the delivery catheter. Basically, at the end there's a balloon, and you deliver it similar to the aerosol balloon, but you're putting in hot liquid, 95 degrees saline, into the segment, calculated again as energy per dose, energy per gram of lung that's available. So we've done 4 patients. 2 of them have had 2 treatments, and 2 of them have 1 treatment, so really small numbers. But I thought that I'd let my colleagues know here what's happening, and just to give you a feel for what's going on and what potential options there are in this space. So this is an example of one of the patients that we did. And right upper lobe's the most destroyed at 44% at -950. Right upper lobe fissure is 39%. Right upper lobe and right middle lobe fissure is 68.5%. Completely, it's completely positive collateral ventilation. And this is another patient that we did again. Very, very similar analysis of destructions by segments. It was mentioned, those that are seated this morning, that these analyses have no anatomical meaning, apart from LB1, 2, LB3, LB4, LB5, they're correct, but the subsegments, they just label with anything. They used to label A and B, and then when I questioned them, well, that doesn't look like A, that doesn't look posterior, that doesn't look cranial. They said, oh no, we just put a letter after it. So I said, look, you're confusing me. Give me 2 other letters that mean nothing, and I'll work out whether X is A or X is B. And that's unfortunately, the companies, including Theroma and Vida, that does this, have not utilised analysis of segmental, and it's up to you to determine that on a 3D model. So these are our first 2 patients that we treated, and we have a plan. So we determine what segments we need to treat, we determine how much energy needs to be given, and this patient, I determined whether it was A or B. So this patient we treated RB2, AB and RB3A. We're limited to total volume that we treat because it's a first-in-human procedure. This patient has significant destruction at -950. And this is the other patient. We're limited to lesser volume because he's got smaller lungs. And this patient also has significant destruction in RB1B of 66%. These are their lung function, very similar, FFV1 30%, residual volume high. I think the high residual volume is really important. I think the higher residual volume, the better they do. And DLCO 30 to 42%. So similar type of lung function. This is our first patient, baseline coronal CTs after treatment of right upper lobe. 3 months later, that's what right upper lobe looks like. It contracts, you see the volume loss, you can see the fissure being pulled upwards, you see the Hymen going up. This is after treatment of the left upper lobe immediately the day after, and this is 1 month after. Again, you're seeing volume loss bilaterally. Again, similar to BVA, similar side effects that you've got to watch out for. Pleurisy and hemoptysis, and that needs to be controlled. We routinely give steroids afterwards to try to control the inflammation. This is our second patient, baseline after treating right upper lobe. 3 months afterwards, treatment of left upper lobe, and treatment of left upper lobe a month afterwards. So that's the type of progression of changes that you see. This is his lung function, patient 1, baseline 0.95, after first therapy, 1.03 pre, and then after second therapy, which is just done recently, FFV1 1.49, but more importantly, the residual volume, 5.84 to 4.2. N of 4 at the moment, but just showing you our data as it comes. Our second patient, FFV1 baseline, 0.93 after the first procedure, pre 1.02, after the second procedure 1.46, 1.48, but again the residual volume 5.26 down to 3.51. Really quite impressive lung function changes. The symptoms are significant. There are adverse reactions. You do have to watch out for streaky hemoptysis for about a week or so. We had to use nebulized tranexamic acid in one of the patients, but after a month or so, those resolve and their functional capacity, their exercise tolerance is quite dramatically improved at least 5 months after the first treatment. So I've mentioned that. So who do we think it's for? Severe, very severe COPD, the higher the residual volume, the better. Those that have nickel allergies, and we've got a few of those that can't have internal valves, and we look at segmental heterogeneity, and we also got to consider safety. In the last couple of minutes, Rajesh, if I have time, I want to talk about another study that we're doing, which is called a Breathe One study, and it is again for patients with incomplete fissures, and it's the installation of a nitinol airway bypass device which we insert into the distal airways, designed to disrupt the distal smaller airways to allow the release of trapped air beyond those small airways. So these are for patients with a greater degree of emphysema. We're looking at a minimum requirement of at least 35% destruction at minus 950 Hounsfield units. So it's a very specific group that we're looking at. This is what the actual coil looks like. So it's nitinol. It's not like a stent. It's round very, very loosely, and it's 10 millimetres in diameter, and it's got a lot of radial strength, and the idea is to disrupt the distal airways. This is the delivery device. The actual device is in the sheath. You retract that, and the actual device is deployed. Again, like the other strategies for treating patients with incomplete fissures, fissures don't matter because we're actually trying to release trapped gas distally. So careful ventilation actually is a bonus because it helps deflate surrounding segments, surrounding lungs. So again, this is the type of patients that we see. Minus 950, RB1, 67%, 65%. So they're probably the two segments you target in the right lung. In the left lung, you've got targets at LB1, LB2, and perhaps even LB6. So we put 2 to 3 devices into the most disease segments in one lung, and then follow it up a month later with the other lung. We also look at gas trapping by looking at expiratory films assessed at minus 856 Hounsfield units, and we actually can calculate how much air is trapped by the difference in those two measurements. There are different devices for different segments because these devices are anchored proximally in the segmental airway and they go distally, so depending on what segment you're targeting, they're different length. And it's done under II control, and that's what the actual loading device looks like. You pull that back gradually and the actual device deploys, and you generally see proximally it's quite narrow because you've got bronchus with cartilage, but you see distally, particularly when there's emphysema, it fans out, and the more disruption there is, the more dilated the distal end becomes. This is what the device looks like proximally. It's not a coil, it's completely different to the coils that you see, and they're easily removable. At the time that you place them, you just use a forceps, grab it and pull it out. However, we've now done the second procedure in 2 of the patients, and we use the MP190, which someone had bitten with those dots there, and we look at whether or not it gets epithelialized right. And so this is the same picture as that. The second time, you can see that the actual coil's been epithelialized without granulation tissue. Again, only 1 month after the initial procedure. And this is another patient that we put in 3 devices in the left lung, and again, that's what they look like. So the 2 patients that we've done 2 procedures on, baseline FEV 1.54, improved to 0.7 afterwards, then just before the second procedure, 0.66, immediately after the second procedure, no change. Residual volume, 5.26, improved to 4.45, down to 4.41 before the second procedure, and down a little bit more after the second procedure. So early days, I'm just giving you a very preliminary snapshot, really just to show you what some of the things that we're doing. Second patient, very, very similar. Baseline FEV 1.45, afterwards not much change. Residual volume 4.17, 3.71, back up to 4.13 just before the second procedure, and down to 3.7 last week. So again, nothing conclusive. It's really just watch this space. So 5 patients have been done in Australia, 2 at Royal Melbourne with Dan, 3 with us at Macquarie, and because it's first in human, the safety committee is now reviewing the first 5 patients, and that's where we're at the moment. So I think there's definite options there, and I think that we've learned so much in the last 15 years as to who we should be doing that. I think that there is increasing evidence for the use of polymer foam sealant in this group to reverse collateral ventilation, then use valves. And I think that the evidence in this group is developing, and I really can't give you anything conclusive at this stage, but I think there is promise. So I'll end my talk again with this image, which I've shown a few times, to really highlight the essential nature of having a multidisciplinary approach to these type of patients as to what option is most appropriate for which of the patients that you see. So thank you.
That's a really nice overview, and it's really fascinating to see all the trials that are happening in this space, so that's great. Whilst Pragnesh puts up these slides, we can take questions from the group for either Alvin or for Fan. Any questions? Go on.
Thank you. Fantastic, fascinating procedures. I'm just wondering, with significant bullous disease, do we just assess that as per its lung destruction score, or should that be considered separately? Significant bullous disease, should we just consider that as per its lung destruction score? Or
So I might not have had it in the slide, but if there's a bulla greater than 30% of that lobe, you generally wouldn't do a procedure bronchoscopically, at least. You may have other opinions about that. So, but from a bronchoscopic lung volume reduction perspective, you would avoid, yeah.
So that's the value of having multidisciplinary clinics. We'll have a co-thoracic surgeon there, and if they were fit for surgery, I think a bullectomy certainly would be an appropriate option. But be interested in your opinion.
What we might do is get Pragnesh to finish his talk, and then we can open questions to both Fan, Alvin, and Pragnesh together, because a lot of these questions will overlap. So, Pragnesh, if you're ready.
Okay. Thanks very much for the help. Good evening, everyone. I'm Pragnesh. I'm a cardiothoracic surgeon. I work at Charles Gardner Hospital and some of the private hospitals. And I actually feel very grateful to be among all of you. Normally don't get to see a lot of the respiratory physicians and the respiratory doctor together. The title is the update, and I must say that I've gotten updated by the 2 very great talks that has been given today. I'm not sure how much I will be able to update you regarding surgery, because unfortunately there hasn't been a lot of update in surgery. Surgeons are very visual, and when we look at CT scans or images or anything, our brain just looks at the lung, how it looks in real life, and that's generally the way we work. If you look at the bronchoscopy or you look at the blood vessels, my brain just sees them as they are. So there is no imagination, and we see the things that they are. We see the problem, and we deal with the problems, and we deal with others' problems too, without a problem. So today we talk about surgical lung volume reduction, and I'm just going to touch base on a few little stuff, which is a pathophysiology. When do we do it? Importantly, as we are always taught in surgery, when you shouldn't do a procedure, and how do we do it. The surgical treatment of emphysema has been revolving around bulectomy, lung transplantation, and lung volume reduction surgery. And obviously now I can't say the new kid on the block anymore, because I was surprised to see so many trials on the bronchoscopic valves and other therapy for emphysema. has already been taken place. So I wouldn't call it a new kid on the block. But certainly it's quite exciting because as a surgeon, I always thought that the surgical treatment for emphysema was always just restricted to heterogeneous disease that was located to certain part of the lung. But of course, with the introduction of the bronchoscopic valve, that opens up the much more localized or unilateral emphysema or more difficult patients who are not suitable for surgery. So thank you very much for the updating about the bronchoscopic lung volume reduction surgery today. What is the aim? Whenever we see the patient, what are we trying to achieve? Are we trying to make the CT scan better, chest X-ray better, or the patient better? So the most important thing, of course, as you all would agree, that the most important person or elephant in the room is the patient. We want to improve their symptomatology. They've got an end-stage lung disease. We may not be able to make them live longer, but can we make them live better? And that is the goal of all the interventional therapy, be it surgery or be it bronchoscopic, is aimed at. As I said, we are visual. This is how we see the lung. I have CT scans, but not as nice CT scans as been shown before, but this is what we see. The emphysema is defined as the permanent destruction of the alveolar spaces distal to your terminal bronchiole, and basically a bag lung. It is an anatomical diagnosis. Clinically, it manifests as COPD, which is a combination of clinical features of air trapping, big chest, blue puffers, pink puffers, and things like that, which I learned in medical school, but of course I must say that I don't have to come across because you guys do. It was first described by Laennec in 1834. As surgeon, we always like to look back into history. Some of the things about the things which are presented earlier, like coils and draining the air spaces into one bronchi, all those things actually date back to what was surgically thought of to treat emphysema. And now this is now being renovated as a technology which can be practiced as by the interventional pulmonologist. So history is very important because when we look back, we actually can learn a lot from what we have done in the past. Emphysema is of various types. Whether it is important in what we do or not, I don't know. As a surgeon in multidisciplinary meetings, frequently it gets described as emphysema, which is centered around the lobules, or an emphysema which is centered around the septa, or emphysema that has affected the whole lobule. Does that make a difference to what we do, whether the CT scan looks like this, or look different? Whether the therapy that we deliver changes according to the type of emphysema, I don't know, and I'm very happy to actually learn from the respiratory colleagues. What does it do? Emphysema, it causes, most importantly, ventilation perfusion mismatch. So we have a lung that is a dead space or a poorly ventilated, but is still perfused. So you have a blood that is going past, which is deoxygenated. The blood is going past alveoli that is actually not functioning and mixing. So you're basically getting a VQ mismatch, and these patients develop symptoms because of the hypoxia and increased carbon dioxide. Second problem with emphysema that causes is elastic recoil. My apologies, my slides are all about anatomy and how it all works. It's a bit different because that's the way we look at it. Because what exactly emphysema does to lung? This is the question that I would normally ask when I was in my thoracic training. That what actually, there are big spaces, this and this, but what is actually doing to the patient's breathing and why? So normally your terminal airways remain open because of the elastic recoil, because of the traction forces generated by your alveoli. Now emphysema is the destruction of your alveolar walls. So if your alveolar walls are destroyed, what you basically get is a loss of traction on your terminal bronchioles, and they tend to collapse and close. And that is how you develop this one-way mechanism where the air can go in but cannot come out. And that is how they keep on developing big air spaces and big dead volume spaces, while the lung fibrosis does totally different thing, but that's not the topic today. The loss of elastic recoil ultimately will do something like this, where we see this is nicely demonstrated on a CT scan, the upper lobe dominant emphysema bilaterally. And when the airways can't open anymore, what it does is increasing airway resistance. And that's when the patient is presenting to you with the symptoms of COPD or emphysema. So for me as a surgeon, when I look at it, I have to trace it back to what is the basically anatomical problem that is causing those patients' symptoms, and that is how I think about it. The other way to look at it is basically this big dead space is a constant pneumothorax or a trapped pneumothorax. When a patient comes to us with a pneumothorax, what does a pneumothorax do? There's air collected in your chest outside the lung, compressing your normally functioning lung. So a patient can't breathe and get short of breath. What do? We drain the air out. Essentially what we have done. What we have done is we have allowed the normal lung to recruit itself and allowing it to function more, alleviating patients' acute symptoms. But these patients are basically a chronic stable pneumothorax, where their normal lung parenchyma that could have functioned well is chronically compressed. So if you get rid of this stable, constant pneumothorax, will allow normal lung parenchyma to actually participate in patients' respiratory mechanics and improve. So this identifies the principle of lung volume reduction surgery. Basically, it centers around removal of the dead inflated lung. It allows the compressed or defunctional lung to become more functional. It will improve the VQ mismatch because you're removing all the dead space. There will still be some VQ mismatch, but it will minimize it. It improves chest wall mechanics. So we call them barrel-shaped chest. What is that? That is because the patient's chest has been ballooned up with a static lung volumes. It cannot move in and out. Wide airspace, wide intercostal spaces, depressed diaphragm. So when we take out the dead lung, we reduce the lung volume. When we reduce the lung volume, we allow intercostal muscles, diaphragm, and other respiratory muscles to participate in the mechanics of breathing. And that helps or should help in patient symptomatology. Sorry, I'm not that overweight, but this thing is squeaky. It reduces pulmonary vasoconstriction. So being a cardiac surgeon, I know during cardiac surgery, if I overinflate the lung, I ask my anesthetist, can you do a Valsalva? Can you just put in a lot of volume in the lung? The patient's PA pressures go up and the blood pressure drops. So one of the things that lung volume reduction surgery does is by clearing out all your dead lungs and making your lungs smaller, it improves pulmonary venous drainage. By improving pulmonary venous drainage, it reduces pulmonary vasoconstriction, arterial constriction, thereby reducing pulmonary pressures, thereby reducing a load on the right heart, thereby reducing the, all the effects that you know of the chronic COPD on the right heart. In the end, this all looks nice on paper, but our patients should feel better. That's the end goal. If we may not make them live longer, but can we make them feel better? Otto Prettington is an American surgeon and an anatomist. This gentleman thought of this concept a long time ago, and he decided to cut out patient's lung. He didn't actually cut out the lung, he actually rolled the lungs and plicated them. He did the operation, produced good result, but had a very high mortality. About 20% of the patients died. And he was told this operation is rubbish. Patients with emphysema, end-stage emphysema, have a 5-year survival of about 4 years or whatever, and 30% of them die with surgery. What's the point in doing the operation? This operation did not become very popular. Then this gentleman, who is still alive, Joel Cooper, he introduced lung volume reduction surgery via mediastenotomy, but he used staple resection of the lung. His mortality was about 4% or 5%, and his series shows very good result, improvement in the percentage improvement in the FEV1 and the increase in the exercise capacity of the patient. So then the surgical community and the respiratory community developed some acceptance of the lung volume reduction surgery. Then it led to, as it happens, when the technology comes, new operation comes, everyone wants to do it. And everyone puts their brain to it, and the new technology develops and new ways develop of doing and achieving the goals. And it kept on going. A lot of operations in America of lung volume reduction surgery. Became very popular, it became the treatment for emphysema. But then it was banned by Medicare in America. So they undertook about, I think in 1996 or somewhere thereabouts, they did a review of all the patients who were admitting with the lung volume reduction surgery and how they were actually doing in a postoperative period, whether the admissions were reducing or not, whether their symptomatology was getting better or not, and the amount of money that was being spent on the treatment, medical and readmission, that did not make sense to them. So they said, yes, that's all look fine in the small series, small randomized control trial, but something is not right. What is published, but when we do our massive database analysis, it doesn't make sense. So they removed the funding. And as you know, once they remove the funding, same in Australia, if the funding goes away, we can't do a thing. So it stopped, but it did not stop it there. The Medicare and National Heart and Lung Institute in America funded this famous trial, which is called NET trial. This is National Emphysema Treatment Trial Research Group. This trial was done across about 17 centers. Initially, they enrolled about 3,500 patients, and about 1,300 patients were then randomized to two groups. One was for surgery, that was lung volume reduction, and other one was for standard medical therapy. What was the aim? First of all, do no harm. These are all high-risk patients. So the first aim was that we have to identify in whom this operation is not good. Patients do bad. Second aim was, is it going to improve survival and look at mortality and improvement in exercise capacity, which was the main important thing because that's what is going to make patients feel better. After 24 months, patients' exercise capacity improved significantly in patient with the surgery group compared to medical therapy. But there was no difference in the mortality. There was no difference in survival. That does make sense. These patients were then further subdivided into 4 distinct groups according to the distribution of the emphysema and their exercise capacity. I apologize if some of you already know about the trial. Apology for boring you, all of you, but this is important surgically because surgery is entirely based on this trial. So, first group was upper lobe dominant emphysema with low baseline exercise. The second group was upper lobe dominance with a high baseline exercise, and the other 2 groups were exactly opposite. This is the summary of the 4 groups, and it is actually quite important, and that is why the surgeons will accept certain patients certain way and might not agree sometimes that you ask a surgeon, can you just take out their emphysema from the lower lobe, and surgeon might be a bit hesitant. Because the trials showed that when your patients have an upper lobe predominant emphysema and a low exercise capacity, mortality improved and patients' exercise capacity improved and symptoms improved. So this is the group that actually achieved the most. The second group that was upper lobe dominant emphysema and high exercise, there was no change in the mortality. Again, makes some sense. When the patient have a high exercise capacity, their VQ mismatch or oxygenation or tissue metabolism probably is already used to something that they are doing, and they're probably not going to change their survival or mortality. Interestingly, their exercise capacity was improved, and it was questioned whether that was psychological. Then other 2 groups are important and interesting. Non-upper lobe, which is the lower lobe or middle lobe, and low exercise, there was no change. Non-upper lobe and high exercise, there was increased mortality. So that was the first aim, identify patients in whom you will not do lung volume reduction surgery. So if you have a patient who has a non-upper lobe predominant emphysema and can walk 400 meters in 6 minutes walk test, well, you got a question, whether this patient's is symptoms, he has symptoms and he's upset and he can't do what he wants to do, but am I going to make him better? So this is the group that that the surgeons will not offer surgery. So when and who derives from this? Ideally, we should have MDT, because this is with the lung cancer, and many other things, cardiac surgery, I've realized, working with physicians and allied health and everything is really, really very, very beneficial. And I don't know if the MDT that does the emphysema surgeries in Perth, I'm not sure. you mentioned that in Sydney you have MDT, which is good. We don't have that, and probably to do with the volumes and interest of the surgeons and the physicians. But I think MDT is, first of all, very important to identify right patient, do the right thing. For patient selection, some basic important things which has been outlined before, that there has to be severe emphysema, which you saw on the CT scan. It should be pretty simple, visual. You don't need percentage calculation. You just see it and you know there is emphysema, it is there, it is upper lobe dominant. There has to be marked restriction in activity of daily living, and your respiratory physician has tried everything to improve that patient's symptoms. Age less than 75 years, I mean, this is kind of a bit controversial, but I will not discuss that much about the age limitation. And should not have smoked for about 6 months. I'm pretty stringent when a referral comes for lung volume reduction surgery about the lung function test and what it measures. FEV1 less than 40% or 45%, there should be hyperinflation measuring TLC and residual volume, and DLCO should be more than 20%. You do ABG, PCO2 should be more than 55 or 60, PO2 more than 50 or 60, PCO2 less than 55. Walking capacity should be at least 140 meters. It's again, pre-rehab or post-rehab is again a bit controversial, but if it's more than 140 meters, they are good candidate, then I would be happy to accept them for lung volume reduction surgery. Cardiac assessment is very important because all these patients who have emphysema, they're smokers and they have all the risk factor for cardiac diseases too. Not only the cardiac disease, but it's also important to know whether they have end-stage emphysema with pulmonary hypertension, with right heart failure, with tricuspid agitation, with atrial fibrillation, are all important assessment that as a surgeon, when the patient will come to me, I will have to make. And that is not, it doesn't affect what I do as a surgeon, but it does affect in patient's risk management. Radiology, I'm very impressed with the pictures from Adelaide, with the fissures and the colors. I not only of patients, even I will be impressed if I got the colors, because I don't have to look at anything. I just see it and I know where the problem is and what I'm going to target. But this is what we get currently, and these are two things that you need to have: CT scan and VQ scan, and both should match. So you have upper lobe dominant emphysema, and you have a VQ mismatch in the upper zones. And that for me is a patient satisfying other requirement, would be a good patient. So I told you when I will accept the patient for LVRS and when I'll operate, or when I will not, or when I'll be hesitant. And that goes to what kind of complications were noted in NETS trial, and what were the predictors, univariate or multivariate, for complication rates and problems, and based on which you have the criteria for which you say you will operate or you will not operate. So predictor of mortality following lung volume reduction surgeries were advancing age, declining exercise tolerance, increasing PaCO2, like carbon dioxide, decreasing FEV1 and DLCO. And that generally will form your exclusion criteria. There are many exclusion criteria, but these are kind of, that is how the exclusion criteria were actually looked at, that where you will not operate the patient. Among the many, I've just outlined the common things which will, so if the patient has a previous lung transplant, of course not. If the patient had a lobectomy on the same side, I won't be accepting the patient. If there's a diffuse emphysema, if I see as a surgeon emphysema everywhere, we do get told, it is upper lobe dominant by the radiologist, and it's more in the upper lobe, it is not in the lower lobe. It's sometimes hard. I don't think as a surgeon we have advanced to the stage of respiratory physician where you look at the Hounsfield unit and then you do the 3D calculation of the capacity of the VQ mismatch and everything. I'll be very wary unless I see a clear-cut upper lobe dominant emphysema. So diffuse emphysema, I'll be hesitant, but I'll be of course, and in the MDT setting, where the surgeon can be convinced by the respiratory physician, the radiologist, and the nuclear physician that this is the area to target and we're not going to cause any harm to the patient. Yes, of course, we will be able to do the operation. Patients who are not cooperative. I mean, for me as a surgeon, it's very important. We don't do a lot of LVRS surgeries, but whenever we do, I tell patients, look, this is not a walk in the park. This is not 2 days in the hospital. I do a lot, I mean, for years, we've only done, I haven't done a thoracotomy for past 7, 8 years. I mean, we do in and out VATS surgery. But I tell patients that this will require, this is a project. This is how I tell them. And the project has multiple facets. And you have to pass each facet. You give up any time, you are a failure and you're going to back to square one and you may even die. So it is very important that you want a patient who's switched on, because this patient can get frustrated. They put in effort, they go and you do all the physiotherapy and everything, and then they don't get the result. They go for surgery, they get air leak, they get surgical emphysema. It's not a happy time for them. So it's very important they are very proper and appropriately counseled and made to see what is potentially coming. Stopping smoking generally is a very good sign. Any patient that has stopped smoking for 6 months normally will tell me that they're pretty strong up there and they really want this. I mean, that for me, when a patient has already stopped smoking, by the time there's senior respiratory physician has come to me and they haven't smoked for 6 months, they've done they're sort of convincing to us. I don't think anybody does those blood level of nicotine and things like that to see whether the patient is secretly smoking, but I don't think we do that in Australia. FEV1 of less than 20%, DLCO less than 20%, they should go straight for transplant. They're not a candidate for LVRS. BMI of less than 25 or BMI of more than 35. Do you see patients with BMI of more than 35 with a COPD? When I was going through all of this, I said, oh, that's weird, but anyway, that's exclusion criteria. Pulmonary hypertension is not a good sign, and post-rehab walk, if the patient hasn't improved, it has multiple. Rehab is actually, again, quite informative. When the patient is doing rehab, either he's actually trying very hard and doing everything, he is not able to increase his walking distance, or his muscle mass is very poor, or his heart is very poor, or he's not putting in enough effort to achieve the walking distance. This is a very good surrogate marker, again, for patient selection and pulmonary rehabilitation. Post-walk improvement becomes a very good parameter for me to see whether this patient is going to do well after surgery or not. Because as a surgeon, we don't see patients as often as you have seen, because these patients are chronic emphysema and they with the respiratory physician for a long period of time. You know their psyche, what they do, what they don't do. I have 30 minutes or 40 minutes in my clinic to make that assessment. So for me, when these things are there, it actually assures a surgeon in taking a decision. Next thing is how. Stenotomy. Stenotomy allows a bilateral approach. I'm not a big fan of doing lung surgery via stenotomy, but we'll talk a little bit about stenotomy down the track. But stenotomy, and then there's a VATS, and there's a robotic as well. So hopefully from August onwards, we will be able to offer robotic lung resection in Perth, because that's when I'm getting my accreditation for robot. So VATS or robot lung resections, unilateral or bilateral, and I put bronchoscopic as a little bit small because when I was preparing these slides, I did not know that there were so many trials. Otherwise, I would have put it in the big letters too. When do you do unilateral lung volume reduction surgery? And as I was just looking at your series, all of them are mostly unilateral. And I'll come to that why that is important as a surgeon for us. So you do unilateral lung volume reduction surgery when there's a localized disease. It's clear cut and you think, yeah, okay, we could make the patient better. It's significant, is occupying 50% of the hemithorax. Yeah, I think we could improve the patient. Patient have a contralateral pleurodesis, that means you don't want to go in the patient's chest, it's surgically hard. If there is a prior contralateral lung resection, then you would just do unilateral lung volume reduction surgery. Now, there are some factors that you might start as a bilateral lung volume reduction surgery, but you end up only doing unilateral. So if the patient becomes unstable. So some of these patients may have a bad right heart, they may have TR, and they are on a single lung ventilation when we're doing operation. They become hemodynamically unstable, we will stop at unilateral. Or if you do one, and there's a massive air leak coming out of one, then as a surgeon, I'll be a little bit hesitant to do bilateral because whatever patient is breathing here is coming out in the drain, well, it's a problem. So then you stop at unilateral. So for the bilateral can be done in a supine position. I have not done this, but this is Joel Cooper's approach. So when you have a bilateral approach, you basically have ports on either side and patients in an extremely extended chest position. Or you can do bilateral thoracotomy approach. Thoracotomy is not something that I like. I would either choose a sternotomy or VATS. So VATS is simpler. You have 3 ports and it can be done bilateral. Little incisions, no rib spreading, no bone cutting, no neurovascular bundle damage, obviously more patient friendly. So what the surgeons have done so far and what kind of information exists, whether it should be unilateral or bilateral. Robert McKenna is a very renowned lung surgeon from the US and has been operating for more than 25 years and was one of the participants in NET's trial. So this was a series where he randomized patients sequentially to unilateral and bilateral lung volume reduction surgery. And what he found was that the bilateral procedure produced a mean improvement of 57% compared to 31% in FEV1 after the unilateral versus bilateral lung volume reduction surgery. So bilateral lung volume reduction surgery patient did better. And importantly, what he also found was in a borderline patient, if you did do a unilateral lung volume reduction surgery, their 1-year mortality was actually higher. So his study, which was sequentially randomized, what he did was he did 50 patients all unilateral, and then he did another 50 all bilateral. Of course, there is the technology changes, the time changes, a lot of things changes in that. So those factors are accounted for, not completely accounted for in this study. But nonetheless, he very nicely displayed that the bilateral was better than unilateral. And then as after one, many other things comes in the literature, which is good, because what multiple publication tells us that either we all agree on what we are doing or we completely disagree on what we are doing. So you can see that it's early on was unilateral and then it went on to bilateral and became much more acceptable practice to do bilateral lung volume reduction surgery to produce significant improvement and lasting improvement in FEV1 as well as patient symptomatology. Okay, so whether we should do it sternotomy or VATS. Sternotomy is actually quite a good incision. I've done thousands of sternotomy, and I'm also quite a busy minimal access surgeon, whether it's heart or lung. Sternotomy is a good option, but we must accept what patients don't like. None of you will like if you put your hand on a sternum. No, I don't want you to go there. It's actually quite a painless incision, but it's a very useful incision, because you can access the target area from sternotomy pretty easily. One of the drawbacks of sternotomy in a patient with a COPD is that these patients can have air leak, they can cough, they can have increased work of breathing. So they tend to move their thorax quite a bit, they cough a lot, they have increased risk of sternal wound dehiscence or malunion. They are generally also malnourished, and we generally think that patients who are malnourished also have a high risk of sternal dehiscence. So although sternotomy has produced very good result, it's not a very popular approach. VATS, as you know, is the thing to go. So this was from a national emphysema, same NETS trial. So what they did was, some of the center internally randomized LVRS patient to sternotomy versus VATS. Found no difference in mortality, found no difference in symptoms, found no difference in change of FEV1. So it tells you, yeah, I mean, approach doesn't matter as long as you do the operation inside properly, patients are going to benefit. subsequently, many series got published, and the series concluded that VATS was associated with the better patient satisfaction, lower hospital stay, early mobilization, lower sternal wound adhesions, lower sternal wound infection, and then subsequently VATS became a standard of care in patients with lung volume reduction surgery, and now it's going to be robotic. I see no difference, but anyways. So Rajesh texted me that I should express my view on this trial, and I am actually not there to express my views, but I did read the trial. And this is the only trial. So earlier trial that were presented, and correct me if I'm wrong, were between the standard medical therapy versus valves. This is the only trial that compares valves versus lung volume reduction surgery. So I found the trial interesting. But nonetheless, I think every trial, you can criticize as much as you like, but you still always learn a lot from the trial. So, but my job is to criticize this today. So I'm going to just tell you what I criticize, what are my criticism. So their main aim was to see whether the LVRS was superior to bronchoscopic lung volume reduction surgery. Currently, there is a trend of a non-inferiority trial. So it amused me that this was a different type of trial. 88 participants, and there was a 12-month follow-up. Both treatment produced similar improvements in gas trapping and percentage improvement in the FEV1, and no difference in mortality. So both groups did well. But as Alvin and Dr. Nguyen mentioned, that they were highly selected patients, and both of them did well. So while reading the trial, what are the things that I see as a surgeon about the trial? And so if I get a patient, am I going to tell the patient that, oh no, you don't have lung volume reduction, but you should rather go and have a bronchial valve? And why would I say that? And why wouldn't I say that? So CALEB included patients with unilateral procedure only, while the approach for why the bilateral lung volume reduction surgery has shown to produce significant advantages over unilateral lung volume reduction. However, if you put in one arm unilateral lung volume reduction versus unilateral bronchoscopic lung volume reduction, you are comparing already inferior surgical arm to what we propose as standard bronchoscopic treatment, which is bronchoscopic lung volume reduction surgery. What I mean is that if there was a 30% FEV1 reduction, FEV1 improvement with the unilateral lung volume reduction, and with the bilateral that was 50%. But now you're comparing 30% of the unilateral LVRS to bronchoscopic LVRS, and both look equal. But we haven't offered those patients what we would have normally offered, is bilateral lung volume reduction surgery. And there could have been a difference. But I understand the trial, because if then they would have done bilateral, then there would have been different criticism. Well, you treated one group bilateral, but then the bronchoscopic was unilateral. So I understand why the trial is designed that way, but it's important to understand if there is no difference, why potentially there is no difference. Highly selected patient, it did require complete fissure, and of course, as has been highlighted, and incomplete fissures were excluded, and there was no equipoise. Selection criteria was FEV1 was less than 60%. Now, I'm not a respiratory physician, but I've done a lot of lobectomies at FEV1 at 60%, just based on patient's DLCO and also based on patient's functional capacity. So to me, I, as a surgeon, will think that the patients should have a really severe emphysema to qualify for a surgical intervention. So would I have done unilateral LVRS in a patient who had FEV1 less than 60%? I would have argued very hard, but on a trial setting, I would have agreed, because we would want to see the difference in the treatment effect. But normally I would not have, because to start with, they don't have a severe emphysema. So also in surgical arm, they allowed thoracotomy. So those who are not surgeons or surgical registrars, if you do thoracotomy on anybody, your FEV1 straight away, even if it was normal, goes down by 30% in first 4 weeks, just because of pain, postoperative atelectasis, anesthetic, everything. It generally takes about 3 to 6 months for that FE1 to come back to normal. So thoracotomy is therefore thoracotomy is not a very good incision because you're cutting through all the breathing muscles. But they allow that approach, which I find not right because that's not a standard, would not have been a standard of care. And I don't blame them for a small number because it's hard to do very big trials, so probably get by. So do I have time or I'm over? Yeah, okay, I'll just move to all this. So this is what we do in a VETS LVRS. Is a 3-port VETS under general anesthetic. We isolate one lung, a double lumen endotracheal tube. We have a camera port, instrument port, and something to grab the lung. Then we introduce the stapler. The stapler have a seam guard or a special sheath on it. So when we cut, we also put a little buttressing on the staple holes for the air not to leak. We take a piece of lung out, and this is how the staple line look like. This is just a quick video of what we do. This is just a first port, and this is the trocar that goes in. This is 10 millimeter, now we use 5 millimeter. This is the second port for grabbing the lung, so we put instrument through the second port. Camera goes in. This is how the lung look like. So that's the upper lobe that you're seeing. That black thing is the emphysematous lung with upper lobe dominance, and then the rest of the lobes are actually quite small because that upper lobe is so hyperinflated. Sometimes we actually puncture the lobe and cut the lobe to get the air out. This is the stapler introduced. Normally we don't have a thread on this, but there is a little strip to produce the seal on the lung. You can see those strips. So that allows air leak to reduce. And we will cut the lung all the way through the upper lobe. You can see this white bit is the strip which is loaded on the stapler. The goal is to cut out about 30 to 40% of the top. So taking out the space. After that, I tend to do this. It's not standard. What you're seeing is a parietal pleura on the top. So this is what we call is a pleural tent. So I drop the pleural tent over the after lung volume reduction. So what it does, it provides kind of a sealing surface, biologic surface. So when we do a pleurectomy for recurrent pneumothorax, this is what we do. We'll cut out the entire pleura. It just comes off nicely. You don't have to do much. It's like peeling a banana. Not that easy, but that is how we do it anyway. And then, but I don't remove it because I want it to drop on the lung. And you drop it on the lung, it provides a seal on the lung. So the time for dessert, I don't know if it's already served or not served, but deserting points. Lung volume reduction surgery is a good option in a properly selected patient, but MDT or institutional approach will be very helpful. Upper lobe dominant emphysema with low exercise capacity are ideal patient in my view. Non-upper lobe emphysema with high exercise capacity should not be offered surgical lung volume reduction surgery, but of course valves seems to be quite useful. Bilateral VATS approach is favored over stenotomy. The referral and the interest for surgical LVRS has been traditionally low, and I think it probably remain low since now there are bronchoscopic LVRSs coming in. So with that, thank you very much, and sorry for a little bit of a longer talk.
Thank you, Pragnesh. That's excellent. In fact, one of the reasons why I thought we should get a surgeon to come to this talk is because as physicians, we don't sometimes completely understand what a surgeon does. I mean, we know there is LVRS, and we know that is useful for patients with emphysema, but many of us don't really understand. Unless we come to the theater and see what you actually do, it is not that easy. So that's why I thought it's great. We can open the floor to questions, and we got about 10 minutes for that. So questions for either Pragnesh, Alvin, or Martin.
I'm not sure. Hi, Pragnesh. Thanks for the talk. There's a difference, actually. The X-rays you showed were really that of paraseptal emphysema, predominantly on the outside of the lung. And I can see that's exactly where you should do lung volume reduction surgery. It's very different from doing lung volume bronchial lung volume ablation or lung volume reduction by putting in a valve, because we're actually doing a lobectomy, and that's not what you're doing. So these two things are entirely different procedures. So yours is more equivalent, or would be more equivalent, to doing segmental occlusion of airways where the emphysema is most great, as in the original bronchial thermovapor ablation, or with the new things that we would be doing in terms of the water, not more air, but the water ones. So I think it's very different. And maybe there is a problem with you're going upper lobe, which is going to have more paraseptal changes, more peripheral changes, which you can easily shave off, rather than in the lower lobes, which you probably don't have quite the same sort of characteristics of the emphysema. So I don't think the CELEB study actually is comparing apples and apples. It's comparing totally two different things, really. And we would not be doing lung volume reduction endoscopically with that paraseptal change, because we're going to be knocking out a lot of normal, good tissue, and that's a loss. So that's just my comment, really.
Surgery is done on much more homogeneous emphysema in the upper lobe.
An area of obvious when we're looking at that, obviously abnormal.
Absolutely. There's all, the ones that are good for surgery, you've got to have the upper lobe pretty much destroyed and the lower lobe's okay, or okay-ish. But the X-rays he showed were very, very unusual, that there was so much around the edge rather than in the middle. That would be perfect for this operation, but a lot of the ones we do, the upper lobe is pretty much all destroyed, and you take a bit of it off. So it's sort of a partial lobectomy, whereas with the valves, you're trying to do the whole lobe by the look of it. Yeah, so we're only taking a bit of it, but yeah, just with the bilateral versus unilateral, when we first started this, there was no valves. Lung volume reduction was purely surgical, and I started doing them bilateral initially, and the air leaks and complications were such that the patients were in for ages, like 2 weeks, trying to deal with their problems. So I went to the unilateral, started doing unilateral with a view, bring them back and do the other side later. Not a single one came back because, well, I don't know whether it's because they didn't, that it was so bad the first time. Well, they actually got such an improvement with the one side that they didn't, the symptoms, exactly what you were saying. This operation is for symptoms. It's not for the numbers that you generate. It's for the way the patients feel. And amazing, cardiothoracic surgery, you deal with a lot of patients with a lot of symptoms. These patients are more appreciative of their operation than any other patient you come across, because their symptoms are so bad. They can't bend over. There's no way they can put their shoes on. These sorts of things. And they come back to your office after they've had it, and I can walk around the supermarket. Just small things, and you probably can't even demonstrate an increase in their actual numbers that blow out, but they are so appreciative of the effect on their symptoms. And if you can do it without surgery, wow, that's a really good thing, because they're not patients you go out looking for. These are terrible patients. You really try to run away from them as much as possible. So if you can do it with valves and get the same result, go for it.
That's a very good point. Sometimes I also feel like I should run away from some of these patients.
I just had a couple of questions about the valves. One was, how long can they stay in? And are they permanent? Do you remove them ever? And they stay longer, do they cause complication? And the second question was about AeroSeal, and that was, is it only intrabronchially, or can it also be used parenchymally? And does it seal permanently? So one for you and one for
So what neither of us talked about were the really long-term complications of valves. There are complications, some migrate, some get granulation tissue. There's some patients have distal collection secretions because the valves decrease mucociliary clearance, so there's infection. So we really didn't touch any of those tonight, but if you're involved in management of any patients with valves, these come up. Often you'll need to go in because of either granulation tissue infection or the valve stopped working, and you have to remove a valve or allow the granulation tissue to settle, then put something else back in, look at other methods. So what percentage complications? Probably about 1 in 5. I've had patients that have had valves in since 2008, so you know, they can stay in long term, but they are a foreign body in an airway, and they ignore the complications that can potentially entail. So about 20% complication rate, Fan.
Yeah, I'd agree with that. You know, of your responders, which are usually 8 out of 10, roughly, 2 out of 10, no matter how hard you try to place them for whatever reason, you can't get that significant volume reduction. But in those where you get target lobe volume reduction, I'd say, you know, a good portion, more than half of those, they just cruise along and they're happy. You catch them once a year, and you know, symptomatically, that's the main thing that they're worried about. Of those other remaining ones, you know, that 1 in 5, which Alvin talks about, I sort of counsel the patient before we even started that you might be one of those, you know, like a car, you have to come in every 6 months for a grease and oil change. So I sometimes say to them, look, you might need a washout, you might need a re-inspection. The first one I showed, he's still actually got his in, and our surgeon, who attends our MDT later on, not at the first MDT, he called me when I was away at a conference, and he said, "Oh, you know, Mr. So-and-so, I'm seeing him because of a left main coronary that I wanted to do a bypass on," and he casually mentioned you put valves in. Can you please tell me his lung function before I operate on him? So, I mean, he's probably our longest at 7. I haven't done it as long as Alvin. But the only other one where we had a long-term complication was, you know, this was 5 or 6 years later, granulation tissue developed and the valve malfunctioned. You know, it can happen late, but it's a bit rare for it to happen that late. Generally, you know in that first 6 to 12 months that they might run into a problem that may need a rebronchoscopy down the track. Yeah. Yeah, so, yeah, this is a question we get asked from the patient. You know, they might have a nagging symptom such as a cough or mucus production. And it's a really long discussion because almost always after you've taken them out, they regret it. They say, oh, those side effects were less than the breathlessness or the shortness of breath. So a lot of them regret that, you know, that they probably, in retrospect, prefer those nagging symptoms over the breathlessness or the hyperinflation. But we have taken them out, you know, maybe in that 5 to 10%, probably 5% mark, after much discussion and counselling with the patient.
Some of the patients that don't respond or respond initially and then don't respond and reinflate, it's probably due to not that you haven't placed the valves properly, but because I think that collateral ventilation is dynamic. So 100% fissure is not 100% fissure all the time, and it's dynamic. Some channels open up, some channels close. Yeah.
We've proven on repeat CT that a fissure has developed. Yeah, yeah. Sorry, collateral ventilation has developed.
Does having pleurodesis before preclude the patients from having a valve or a procedure like a surgery? Sorry, so the patient has pleurodesis before, like for pneumothorax or effusion. Does that preclude the patients from having a valve or a surgery? Because you're inducing collapse of the valves, I mean the lobes. So basically the visceral pleura is attached to the parietal pleura. So does that preclude from having surgery or a valve in the future?
It doesn't preclude from surgery, but surgery will be very treacherous. So these patients, you saw the lung on the video. Yeah, it's a very delicate lung. So if you imagine if it's stuck with the lung and you have to take it down, we end up tearing lung in so many different places that after we've taken the lung now, we wouldn't know what to cut and what not to cut. I mean, it will look horrible. Procedure will become very long and morbidity will increase. So that's the reason that we would say wouldn't do it. On top of that, if you damage the lung tissue that you are going to cut out anyway, it doesn't matter. But there is a other lobe underneath, middle or lower lobe, that we don't want to damage. We don't want to cause air leak because that's the lobe that patient is going to breathe from. But when we do operation, we need to mobilize the entire lung. So we end up damaging that lung as well. So it's not very attractive, and therefore it forms a relative contraindication.
And I'm not addressing that topic exactly, but we have a transplant physician on our MDT, and I think that those questions have been asked, and none of the things that we do are preclude transplantation, and often they are bridge to transplantation if they're a transplant candidate.
Any other questions? Deval.
This question is for Alvin and Fan. In terms of pneumothorax rates after valve placement, I think that's kind of one of the more dreaded complications. You're looking at your data, you're about 17%. That's better than the average. Typically, it's upwards of 20-ish%, kind of looking at previous studies. So you're doing something right, or better, right? But so kind of a two-point question is that, so any tips and tricks to see how to minimize pneumothorax risks in those patients in terms of selection or post-procedure? There was a multi-center trial out of France a year or two ago. They suggested doing a two-stage procedure, and they showed a pneumothorax rate about 12%, which is significant, improvement from what's previously been reported. And so that, and then there's some signal that, or at least some centers in the U.S. they were reporting that they would prevent people from ambulating within the first 24 hours, and they said they showed they at least expressed that there was significant improvement in pneumothorax rate after that. So thoughts on that, or any tips or tricks during or post procedure to help with pneumothorax rates?
So yeah, Nicole Hirsch actually presented some of our data. I think it was back around 2019 that APCB was on, that we don't do stage procedures in everyone, but do it at risk patients. This, for example, the horizontal fissure is incomplete, and the right upper lobe, you get a target right upper lobe, right middle lobe. But right upper lobe plus right middle lobe is 3 litres, and right lower lobe is 1.2 litres. So if you get complete collapse of right upper lobe, right middle lobe, you've got a very high risk of pneumothorax due to re-expansion of the right lower lobe. So in that stage, and as we published, we presented 3 cases whereby we targeted right upper lobe first and right middle lobe second and didn't get a pneumothorax. Similarly, we presented 2 cases where the right lower lobe was the target, quite massive, 2.5, 2.6 litres, and the right upper lobe sort of less than 1.5 litres, again, quite disproportionate volume, and we did stage procedures, RB 7, 8, 9 and 10 one procedure, and RB 6 the second procedure. Anecdotal, but I mean, that's the way we think when we think there's a risk of pneumothorax.
Yeah, we haven't gone down that. I guess the way it's structured in the public health system is that you sort of want to do it in that procedure. But in terms of first question about the bed rest, yes, a little bit lucky where we are that the patients have single rooms, the ensuite's right there, so we don't really limit them. I mean, they're not charging around the ward anyway. So they're usually limited to the room, so there's not too much ambulation. We don't give cough suppressors for what it's worth. I guess the theory is that the pneumothorax happens in the ipsilateral non-treated lobe. So we haven't looked carefully yet, but I just wonder if the ipsilateral lobe is fairly diseased, are they the ones who are more at risk? And whether we should be doing stage procedures on those, but perhaps that's something Alvin and I should look at our pneumothorax patients and see if there's a signal in those ones. But we don't do the stage purely because of the way the funding is structured. Yeah.
And we've also looked at physical completeness, 95% versus 100%, where there's a greater rate than 100%, and we haven't found that.
There's a question online for you, Pragnesh. Could you comment on uniportal versus standard multi-port VATS LVRS?
We do in a lobectomy settings, uniportal lobectomies or uniportal resections are becoming more and more popular, minimizing the number of intercostal nerve that you're going to damage. So basically when you do 3-port VATS or 4-port VATS, you are putting 4 incisions in a 4 different intercostal space, and there's a potential of damaging 4 nerves. And if you do uniportal, you are only going through 1 port. LVR is a relatively very simple operation, so we do much more complex operations like lobectomy and segmentectomy. I see no reason why uniportal VATS can't be done for LVRS. So answer is yes, definitely can be done. I haven't particularly done it. I'm not a fan of uniport, but yeah, certainly can be done.
Any other questions? Otherwise, I might ask one to Fan and Alvin. And there's always one of those questions that I worry about, and it's extending further the thoughts that Dhaval had, and that relates to pneumothorax post endobronchial valves. I think we didn't discuss it quite as much, but it is a significant complication, and once it happens, it is quite difficult to manage and can also be prolonged. Now, surgeons are used to it, and I think it was Mark who said 2 weeks of pneumothorax with chest drains, they don't worry about it, but I worry about it. And I guess the question is, what do you do when these patients come? And you touched upon it very briefly in your slides, but sometimes they just don't improve even after the initial few days of conservative management. Yeah. And I guess, I know one of the things that you're going to say is take the valves out. I just haven't understood the mechanisms by which, when you take a valve out, the pneumothorax stops. Just wanted to elaborate on that.
I think it's I think it's a tough one. Like, people have thought long and hard about why that works. I guess our theory is the hole must be in the non-treated ipsilateral lobe, whatever lobe that might be, in terms of what's caused the air leak. And the reason for taking the valve out is to essentially re-expand the lobe that you've just collapsed, perhaps to cause a bit more apposition between the lung and the pleura, so that you can try to accelerate healing of that hole so that the pneumothorax goes away. And you hope that by doing just one valve, that's enough to re-expand the lobe, but in order to accelerate the re-expansion, then you might then take the next step to take all the valves out. So for the 10 or so patients that we've had, probably 20% the chest drains fixed it. The other 7 we've had to either take one valve or all valves out, and then 1 we've had to send to a friendly surgeon to fix. That's been our experience. It is a nerve-wracking complication because it can happen without warning. It might happen in the recovery. It might happen, day 2 on a weekend or something, and you hope you've got a very good registrar fellow around to fix the problem fairly promptly. Because by the time I get in, you probably want something done already. We haven't had overly frightening ones, prolonged ones, but not overly frightening. But you always worry that you could get a frightening one. So that's, I guess, my theory on what's happening and why doing what we do works.
So I agree with that, but as we've discussed sort of individually in the past, I think that the guidelines and that algorithm, that complex algorithm Fan showed you, I think there's issues with it, because I think they leave a leaking pneumothorax for way too long. By the time you consider taking a valve out after a week, the patient's deconditioned, and really you want to get them up and about as quick as possible. So Jonathan Williamson and Nicole Hirsch have published the use of blood patches as we have discussed as well, up to 3 occasions to try to improve the treatment of pneumothorax so that you don't need to take a valve out or you don't need to go to a surgical approach. So I think the blood patches which are not on that algorithm are appropriate at a few different situations.
Yeah, what Alvin was referring to was one of my most complex patients we had recently who had a really bad pneumothorax. She had a really bad pneumothorax pretty much half an hour after the valves went in. And we tried all that you said, Alvin, didn't work. And interestingly, the day that I took the valve out, well, pretty much it stopped straight away. And I just couldn't quite understand the physiology behind how a leak could stop within less than 6 hours of taking that valve out when it hadn't stopped despite trying everything else for many days. She didn't want it. Which, Mark?
Maybe it was exactly the same thing happening in the re-expanding or over-expanding other lobes. I mean, I never went back to look at them. We just put up with a chest drain for a long time. Often sent them home with the chest drains. Yeah, so it's an interesting phenomenon. It would be interesting. Has there been any description of the hole where it is? No, but I mean in the literature. Presumably this is, other people see this problem.
I think Martin made a very interesting and important point. I was thinking about it, and that's very good, Martin. Thanks for that. Thinking of that, I just remembered a patient that, although not standard, one of my respiratory physicians convinced me to do a lobectomy in a patient as a part of lung volume reduction surgery. And although it's not standard, it's more like a more diffuse, the whole lobe is gone. And there was basically it was a patient also had a lung nodule, which is a relative contraindication for lung volume reduction surgery. It was highly suspicious for cancer, and initially the patient was worked up for lung volume reduction, taking out the nodule at the same time. And I said, well, this patient was just going to leak air for I don't know how long, because there is no normal lung underneath. I'm just cutting through a normal lung. He said, why don't you do lobectomy? Oh. So never thought of that. Anyway, so we did a lobectomy, and that patient did so remarkably well, taking out the lobe, and that goes in with what you guys do when you collapse the lobe and the rest of the lung expands, and the diaphragm becomes more functional. The patient actually do a lot better. So maybe there is a role to look at where surgical LVRS might work and where the bronchoscopic LVRS might be better. There might be something down the track that they might come up.
We use the VQ lobar quantification because you touched fairly eloquently on the effect of both perfusion and ventilation on the lung, and our surgeons love our nuclear med physician because pre-op we'll do that scan for them for their lobectomies, and it gives a little bit of reassurance that the lobe that you're taking out, because often many cancers are upper lobes, and often the upper lobe emphysema is really bad, and it gives a little bit of reassurance prior to the surgery. Yeah.
Okay, that's great. It's nearly time for us to close. So if okay, whilst I wait, I haven't got it. Okay, well, I think there's one more question, but whilst I wait for that, I might just get to close this meeting by asking Fan, Alvin, and Pragnesh to summarize one reason why, like I'll come to you, Fan and Alvin first. Give us one reason why we should send a patient with lung volume with severe COPD and hyperinflation to you and not to Pragnesh.
Oh yeah, I'll take it. I think that's a loaded question. I think you should send the person who you're considering for lung volume reduction to a team which includes the cardiothoracic surgeon, and together we'll make the correct decision.
How do I follow that up? I don't know what to say now, but if you have an enthusiastic surgeon, that makes a big difference, I think. Our surgeon's like, well, it's obvious your valves haven't bloody worked, so why don't I just take that lobe out? So, but some of the good surgical cases we do, we've actually done the volume reduction with the valves. We've proven that they tolerate a lobectomy. For whatever reason, 2-3 years down the track, there's complications, the valves stop functioning. We've proven the concept, and often those cases are helpful in the decision making. But I think it is nice to have the team discussion and come to the right treatment for the right patient.
Those questions are too nice. So I'm going to ask Pragnesh. Tell us one good reason why all of us here should be sending, because you put in your last slide that there's probably not too many referrals for lung volume reduction. So give us one good reason why we should be sending these patients to you and not to Alvin and Fan.
Like Mark said, you don't go looking for these patients. They certainly these patients are not a surgical challenge, but in a good way, it becomes in a bad way, it becomes a bad nuisance when they are air leak in the ward all the time. I think, to me, every intervention has its role, and it's not a diplomatic answer I'm giving, but I think MDT is very important, like how Martin just pointed out, the difference. As a surgeon, as I said, I'm visual. I see this is bad and I take it out. And once I take it out, I can take it out, patient's fit for it, patient gets surgery. But I think when you are sitting in MDT and identify the right patient for the right treatment for the right patient and doing the right thing by the patient with the minimum morbidity is the goal. So be it whether it's a bronchoscopic valve or be it surgery. So if where the bronchoscopic valve is going to produce, like if it's a lower lobe emphysema, or I'm not going to produce good result, I'm not going to chase that kind of patient. But equally, if there's a dominant upper lobe emphysema bilaterally with likely going to get a very good result from LVRS, then I would say, well, that patient should have surgery, not bronchoscopic valve. So I think that's what my approach would be.
Can I reverse answer that question then? I think that there are very clear cases that shouldn't have endoscopic valves and they should go to surgery. And as Martin alluded to, they are those with paraseptal emphysema, and we'll send them straight to surgery if they're a surgical candidate, and Big Bully.
That's great. I think we should draw the meeting to a close. We had a really nice discussion. I would like to thank Fan and Alvin, who have especially come. They haven't come specifically for this meeting, but they have been kind enough to attend this meeting despite long days at our other workshops. So thank you, Fan, and thank you, Alvin. I don't think Fan will say yes to me next time I ask him something without actually thinking through it. And Pragnesh, thank you for, I love working with you in the hospital, and I know you're a great surgeon, but I think we need to have more discussions with regard to some of these patients, and there is a role for both surgery and lung volume reduction again, but it's great that you provide a really nice overview for some of us who don't really understand the ins and outs of what a surgeon goes through or does when for lung volume reduction surgery. So thank you all for coming. I'd like to thank Pulmonx for supporting this workshop again, and to everyone online who are still awake on the East Coast, thank you for joining us, and good night.